Sure.
Thanks very much.
Okay, thank you. So again, it's just sharing clinical experience, no science. So what I'm going to talk about, the first question is, and it's the same question actually with invasive NAVA, we have to ask ourselves the question, do we really need an improvement in technology? We all know in this room, as intensivists, as clinicians, that we could have new features. We can have new equipment in our ICU every day. I mean, today you can buy endotracheal tubes that measure cardiac output. We have all kinds of advancements in renal replacement therapy. But we, as healthcare workers, have to ask ourselves the questions. Does this benefit my patient? I mean, that's the most important question, I guess. We'll look at that later on. Talk a little bit about the evidence, but that's going to be a very short part. The clinical practice in our unit and some examples. So do we need improvements in technology? I think so. We all know that quite a lot of patients feel non-invasive ventilation, and it's very remarkable. If you go into the literature and you look, why are you going to look for the evidence? Why do patients feel non-invasive ventilation? Why is this specific patient failing? There's not much hard evidence for that. There's not much data. And I think it's a very interesting topic. But we know it frequently fails. And this is an interesting study from a couple of years ago. And what they, I'll do it like this. And what they looked is looking for predictors for failing non-invasive ventilation after 2 hours 2 hours after they started non-invasive ventilation. And the most important one was having a low pH. Basically, and this is in patients with COPD, basically having a respiratory acidosis. So that's an important one. We're not able to adequately ventilate these patients. And it might be that patient ventilator synchrony is a part in that. And I think the data that were just presented about the upper airway are very interesting in this part. So perhaps non-invasive NAVA could play a role there. So this is, well, some preliminary data I'm going to show you of a study that's still going on. It's in patients with COPD, and we compare non-invasive NAVA with non-invasive pressure support. And in the same study, we compare two different interfaces. That is the full face mask and the nose mask. And each intervention lasts for 30 minutes, and this is randomized. So each patient has four different protocols. I'm just going to show you some data. It's very preliminary, but look here. This is pressure support versus NAVA. There's actually no difference in CO2, but there is a small difference in the dyspnea sensation. Patients on NIV-NAVA have a reduced level of sensation of dyspnea. Right here, no difference in tidal volume between the two groups, but there is a significant reduction in trigger delay. I mean, this is not unexpected, and there's a reduction on all kind of, well, dysynchronies and asynchronies. This is a representative slide. This is a patient, non-invasive pressure support. EDI, inspiratory pressure, flow, and you see all types of asynchrony, double triggering, wasted efforts, it's all there. We switch the same patient to NAVA, there's improvement. I mean, it's not really unexpected. I mean, this is what NAVA does, and it does it with non-invasive ventilation as well. And the interesting thing is, this is with the nose mask. Again, nose mask, pressure support, all types of asynchrony, and it goes on and on. And if we switch this patient to this is the nose mask with NAVA, and there's immediately a reduction in the number of asynchronies. So I think that's important information because you can switch between the different interfaces. I'll show you later on a little bit more. This is, I think, the only other study that's available right now in this population of patients. It was presented at the ATS last year. It's a Belgium study. They had patients for 20 minutes in pressure support or 20 minutes in NAVA. Very small study, preliminary data. But what they basically showed is that there was a reduction in trigger delay. There was a reduction in double triggering. There's a reduction in ineffective triggering. As you have heard, it basically doesn't happen with NAVA. And there's a significant reduction in the total number of asynchronies. So I think we can conclude that, well, there's not much discussion. You have seen it so much. There's a reduction in asynchrony or dyssynchronies with non-invasive NAVA. You don't see wasted efforts, and there's reduced trigger delays. A little bit about the interfaces, and this is one of the patients I'm not really proud of. It's a patient with COPD who had non-invasive ventilation in our unit. And because of a lot of leaks, what they did is have the interface really, really tight to his face. And what happened at the end is a very severe pressure ulcer right here. I mean, it's that severe that he needed plastic surgery for that. I think this is a very major complication. So the interfaces are really important, and at least the leakage is very important. Now, you have heard it from Jennifer. With non-invasive NAVA, you don't really care about the interfaces. So how we do it in the protocols right now, we change between the different interfaces, go from full face mask to total face mask, sometimes to nose mask, and even you can use the helmet. I mean, it prevents that you have the pressure ulcer. I think it's very important. Patient can choose which interface he's most comfortable with. I think that's an important advancement. A little bit about the implementation. I think that was really easy. I mean, if you have a lot of experience with invasive NAVA, the non-invasive NAVA training is not a problem. Again, we started with one unit to see if it's an advancement, to see if patients like it. But after that, we had it in the other units as well. Again, nurses now were trained by expert nurses. We didn't really need a company now. We just had the expert nurses training the other nurses, did the keynote presentations, made sure that everybody did understand that the leaks is not a problem. You could switch between the different interfaces. And the training for the doctors was rather easy as well. Just a keynote presentation, and they could go ahead. So which patients do we have on non-invasive NAVA? I must admit, initially, we had all patients on non-invasive NAVA, because if you have a new technique, you need some clinical experience. So just go ahead and see that everybody understands what's happening, that it's working in your clinic. And now, I think it's mainly the patients with obstructive lung disease. And of course, because those are the patients, of course, with the most asynchronies. But also, quite a lot of patients already have a NAVA catheter, are extubated and are weaned with non-invasive ventilation. And of course you use NAVA at that time. Again, the level of support. We could have a good physiological discussion about it, but just do it easy. Just do it like you would do with pressure support. Initially start out with the overlay window, and then twice daily try to reduce the level of support, just like we used to do when a patient was in pressure support. Keep it simple again. Well, a little bit about the catheters. There was some discussion in one of the previous talks. At least in our hospital, it's common practice that all patients on non-invasive ventilation have a nasogastric feeding tube for two reasons. You want to make sure that they don't have gastric insufflation. And the other thing that's important, I'm really sure, a patient who is on non-invasive ventilation doesn't have adequate nutritional intake. He doesn't have enough energy intake, he doesn't have enough protein intake. So in our hospital, all patients on non-invasive ventilation have a nasogastric feeding tube and have feeding through the tube. So I think that non-invasive NAVA doesn't make it more invasive. But that's perhaps open for discussion. So a little bit about the catheters. Yes, I agree. You could use the smaller catheters. But in my experience, I'm a little bit hesitating in patients who are agitated, but because they are able to dislocate the catheter with their tongue. So I would prefer the 16 French catheter. What is important with patients who are awake, that you could use local anesthetics. I think initially, perhaps even at this moment, McKay says you can't because it affects the quality of the catheter. But in my experience, and we did really a lot, you can just use a little bit of silicone spray. It doesn't affect the catheter. So there were questions, there were limitations with the non-invasive NAVA as well. I think most is solved. There was initially problem with PDMS connection. That's solved. Cables get lost. Yeah, that's a problem. I don't have the solution for that, to be honest. But this is an interesting point. Initially, we had complaints by the nurses that there was so much alarms. And we basically did a small study. We had patients for 3 hours on non-invasive pressure support, and then we had them 3 hours in non-invasive NAVA and looked at the number of alarms. And it was basically the same. But when the patients were in another mode, in a new mode, and this was true for invasive NAVA as well, people are more focused to the alarms because they think, oh, what's happening here? They're going to look immediately and try to change anything. And when there would be an alarm in pressure support, they wouldn't care, or they do the things they always do. They're not really focused to it. So we have done the study, and there's not really much alarm. So that was a problem in the beginning. And of course, there was the problem that when the patient went out of the ICU to the general ward, that the connector was so heavy that's on the feeding tube. So I think to close, it's just a nice clinical example. This is a patient, 71-year-old male with congestive heart failure, very severe COPD, chronic hypercapnia, hypoxemia, that was admitted to the ICU because of dyspnea. Well, not a real infiltrate, I guess. And we put him, a colleague of mine who is very, very experienced in non-invasive ventilation, put him on non-invasive pressure support. 8 of PEEP, 10 of pressure support, 60% of oxygen. Look what's happening. 932. There's some wasted effort here, auto-triggering here. There's a wasted effort right here. More wasted efforts. More wasted efforts. Minute ventilation goes down. There's even more wasted efforts. And then it goes on and on. And he was at the point of doing an endotracheal intubation, which I guess is reasonable at this point. But if you switch, not sure it's going, switch it back to NAVA, you switch it to NAVA, you see immediately there are no wasted efforts anymore. You have an increase in minute ventilation. And this patient was actually doing fine. So I think if we want to do the large studies, it's the most easiest way to do it in non-invasive ventilation. Those outcome studies might be the easiest, I guess. So to conclude this, there's not much discussion. And the studies will come, but we know the outcome. Non-invasive NAVA will improve synchrony. And I think real advancement for patients is, and it's an important outcome parameter, it's patient comfort. With non-invasive NAVA, you could have the different interfaces. And I think if you have experience with invasive NAVA, the implementation of non-invasive NAVA is really easy. Yeah, I just want to bring this to your attention. If you still can't get enough of the NAVA and the neural control of breathing, we're organizing a 2-day conference in Nijmegen in April, which will have discussion from a lot of people about this subject. And I think it's, just visit the website. It's going to be great, I guess. Thank you.
Thank you very much. Any questions for Leo? A couple questions, one back here about the fifth row, and then Jennifer.
Hi, my name is John from Anchorage, Alaska. My question is, you've tested the NIV-NAVA with different interfaces. Have you noticed different variability in the signals versus one system versus the other?
So what kind of signals? Sorry.
The EDI signals. Did you see advantages or disadvantages with one interface versus another?
No, we haven't systematically looked at it, to be honest. We'll just, well, perhaps we should do this in studies, but we just started out using it in the clinic. And we'll just see if the patient prefers one interface above the other, that's okay. But he knows he can change the interface whatever he wants. But I don't know if it's going to change the outcome. I don't know.
Yeah, I think that's a very good point. You know that with this technique, there isn't going to be one best interface.
No,
but
I don't think so.
Patients decide their own. I think that's a fantastic approach.
I think so, and I think it's important to let the nurses and the doctors know that there's no need to have the interface that tight on the face. I mean, I don't know if it's a very important outcome parameter, but for patient comfort, it's important.
Well, it's very important. That's why I
guess.
think it's potentially so useful in non-invasive for exactly that reason, because you don't worry about the leak.
Exactly.
The interface becomes much easier, much easier. Jennifer, there's the microphone coming.
So the study that Jean-Paul presented was in newborn lambs. Do you think that you have the same kind of active glottal closure and asynchronous non-invasive ventilation in adults?
That's actually what we are going to look at. I think it's reasonable. I think so, yes. But nobody has the answer at this point. But
I think it is.
Yeah.
I think it was.
You know, when I was in Boston many years ago, there was a patient I was saying to a couple of people in an iron lung, and the same sort of issue, because there's dysynchrony. The patient didn't have an endotracheal tube and had dysynchrony, so he couldn't be ventilated very well. You have to synchronize the patient's breathing. So I'm sure that it's exactly the case.
First study was published 1948 showing that the glottis opens about 100 milliseconds before you breathe in, and the same for genio glosses too. So this is for everyone. Another thing is too that we forgot to say here today is that you can't swallow and breathe at the same time. So your neural output turns off when you swallow, so you can't get any air delivered by NAVA when you swallow, whereas the pressure support or volume control or whatever breath would definitely take the advantage of the open passage, a sphincter that is super tight when you not use it. When you swallow, it opens so you can roll a meatball down there. I mean, in that situation.
It's Swedish.
Are you suggesting that's what we do?
Yeah. I have a question for Leo
Actually,
too.
let's wait.
Could I just have one? The thing is, do you think it's going to take us deeper into I mean, people are scared of non-invasive ventilation, especially in hypoxic respiratory failure. Do you think this is going to bring us deeper into that discussion of people going to be kept on non-invasive ventilation longer and longer compared to what they are today?
That's a difficult question. You know, there's a lot of discussion about using non-invasive in hypoxemic patients. And I think it has to do with, well, first, how much experience do you have with non-invasive ventilation? I mean, that differs between hospitals, and how good do you monitor the patients while they are on non-invasive ventilation? But I think if you can ventilate them more efficiently, you can do better in hypoxemic patients as well. Yes.
My guess is where to be used a lot more is when you extubate patients. In terms of extubation, put them on non-invasive and they have the catheter in already, it becomes quite easy.
Yeah, when they have the catheter in already. Yeah.
Jean-Paul, and then we'll have to move on.
I just want to answer the question by Jennifer. Please remember, as I showed you a few minutes ago, first, the glottal closure against the ventilator insufflations was shown in adults by Rodenstein's team. So I think that in some conditions, it can occur. And just to go on a bit with the swallowing, we've been studying non-nutritive swallowing in lambs since nearly 10 years now. And what's interesting with the non-invasive ventilation, and I think it should be the same with the NAVA or any non-invasive ventilation, is that during REM sleep, and we haven't spoken about sleep today, I think it's important. During REM sleep, you can have bursts of swallows. And during this time, you cannot have any insufflation. So it's important to remember that also in REM.
Thank you.
Okay.